distress, dizziness, paresthesias, maybe they, numbness is what they may sense, chills, or hot flashes. Some patients, when they have not been diagnosed yet with panic disorder, will come into your emergency room with some of these symptoms and believe they're having a heart attack or something's going on. Then when we do our diagnostics and they are not there, then we would classify it as some type of anxiety or panic situation. And then if it happens repeatedly, then we would probably classify them more as a true panic disorder. They can have sensorium or intellectual processes can be altered, so you might see confusion or disorientation. They might have an inability to have good judgment or insight when they're having a panic attack. They can have a lot of self-blaming when they're having a panic attack. They can have avoidance of others with personality disorders. And when they have panic disorders, they can also have sleeping and eating, so they can have a physiological response. So it interferes with their ability to good sleep and eating. Nursing diagnosis, they're listed on page 234 in your mental health book. And you can see that they would make sense. Risk for injury, we said if they lack insight or judgment, good judgment, they could be at risk for that. We already had anxiety, so we could do anxiety related to whatever. Low self-esteem. Obviously, there's some type of ineffective coping mechanism going on, or they probably would not get to the panic state. Powerlessness, they feel like they have no control over the situations. Ineffective role performance, it can affect how they are as a spouse, a significant other, as a mother, as a father. Disturbed sleep patterns. And you all know when you don't get adequate sleep, they affect other areas of your life also, cause a lot of physiological illnesses sometimes when we don't get a lot of sleep or we're not eating properly. So how do we treat the patient then that has panic disorders? Well, your book talks about cognitive behavioral techniques, or CBTs. Of course, medications. Medications are based on the following things. They're selected based on their symptoms. They must be given in adequate doses for some time for the full effect to take place. So, like I said, it's not going to be just take one pill and wham, bam, I'm good. I'm never going to have another panic disorder again. They always are adjusted to the lowest dose possible, and then we work our way up. Older adults especially, because we know that they can have liver issues, their metabolism isn't as great, so they don't need as much medication to be as effective. Patients can experience rebound symptoms or withdrawals if their medication is stopped abruptly. So a lot of these medications will try to taper down once we decide maybe they don't need as much or even need the medication. Because we're putting or using medications, we need to make sure that they have follow-ups, ensure their compliance with their medication regimen, adjusting their dosages, managing any side effects. And a lot of your anxiety and antidepressant drugs are not medications that you're just going to be able to call into the physician's office and say, hey, I need a refill. They're going to say, hey, Heather, you haven't been here for 6 months. I'm not refilling your medications until I come see you. Okay? This is going to be some of those medications that you're not going to be able to free willy just keep getting them refilled, or you shouldn't be without you being evaluated by your psychologist, your psychiatrist, or even your family or your internal medicine doctor to make sure that your medications are working and how are they working for you. And then compliance is always the greatest accomplished when we use the simplest form or the simplest dose allowed. So if we have to have a lot of combinations, a lot of adjusting of dosages, compliance is not always as great as when we can keep them to maybe one medication in a very simple dose. Interventions. Safety is our biggest thing. If we have patients that are having a panic attack or we're having high levels of anxiety, we need to keep them safe. So if you look back here, okay, our lady who's having anxiety attack may be hyperventilating. If somebody's hyperventilating, we want safety. Sure, we want to remove them from the situation, but we got to get them over their breathing issue before we can do anything with them. If I'm hyperventilating, I'm not going to be walking Taylor down the hallway and say, come on, let's get you someplace. We need to have her calm down first because she's going to pass out if I make her walk and she's hyperventilating. So you need to think about, we're dealing with an anxiety disorder, but we also have some physiological effects that are taking place. So we have to deal with the physiological piece first, and then we'll deal with the psychological. So that's where some of our safety comes into play. Make sure your patient is safe. We do want to provide for privacy for them, but if they're having some type of physiological crisis, we have to deal with that right then and then move them to a place of privacy. Therapeutic communication with them, simple and calm things that they can understand. Managing their anxiety, deep breathing, guided imagery, those are the things that will come through therapy that we can help them incorporate or start using when they feel their anxiety or their panic level starting to heighten. Providing client and family education, learning ways to manage their stress, things that provoke their stress, trying to eliminate those situations or deal with them differently. Medication teaching, understand why they can't stop their medications abruptly, understanding why they need to continue to take them. Follow-ups with their physician or their psychologist or psychiatrist. Regular exercise. Regular exercise helps with dopamine production. That's pleasure. It helps with pain and stuff receptors. So regular exercise, not to the point of it causes them pain or discomfort or angst, but taking a nice walk with their dog or their family or their children, something like that. And then supportive organizations. There are support groups for people that have panic disorders or severe anxiety, and talking with other folks that have that may be helpful for them. Our second type of disorder that the book talks about is a generalized anxiety disorder, or GAD. This is that the person feels excessively or highly anxious at least 50% of the time for longer than 6 months. Treatment for this is usually some type of SSRIs, Buspar, something like that. The anxiety disorder is usually due to some type of general medical condition. It could be from some type of substance, so it induces anxiety disorder, or it could be some type of separation anxiety. Empty nesters, you've been told that you have some type of, let's say, Crohn's disease, and now your Crohn's disease is progressing and you need to have a bowel resection. Those are the kind of things, anxiety that is worrisome or chronic more than 6 months. And we can do that as a generalized anxiety disorder. Your third type are phobias. This is an illogical or intense or persistent fear of an object or social situation that causes distress or interferes with normal functioning. We have some different categories. Agoraphobia. Does anybody remember or know what agoraphobia is?
So where you're afraid to leave your house?
Yes. You don't like being in big open places. You would not be going to the mall. You might go over to your mother's, but you would not go to big open area spaces. And some people won't even leave their own house. You're right. but some of them it's more irrational, big open areas. There are other specific phobias, irrational fear of a particular object or a situation. There's social anxiety or phobias that are provoked by certain situations or certain social situations that you're put in. Things you need to remember. You need to understand how and why the anxiety behaviors work. Nurses are as vulnerable to others to stress and anxiety, so just because you know about it does not mean that you won't suffer from it. Everyone occasionally suffers from stress or anxiety. It's trying times right now. Sometimes our paychecks are not there. Businesses have been shut down at times because they don't have enough people to run the business, and you were counting on that paycheck. You have a child that's been exposed to COVID or some type of other health condition, and they won't take them to daycare, so therefore you can't go to your job or go to school. So there's lots of things these days that are interfering and adding to people's anxiety. So everybody suffers from an occasional stressful situation or anxiety situation. You can't fix the patient's problem, so avoid trying to fix them. That's what families tend to do. That's what your mother tries to do sometimes. That's what your best friend tries to do. They try to fix the situation. And oftentimes, that's not the kind of fixing you need. You need some place where you could help manage your stress and manage the anxiety situation within your life. Okay. There are some different types of phobias that your book talks about. You can just kind of read over those. And just kind of be familiar, but for the most part, our phobias are just the fact that you have some type of fear of a certain particular thing or object. Okay? Our next chapter then is obsessive compulsive disorders. And you can see that this is just showing a CT scan of somebody with no OCD and then somebody with OCD, and you can see how much their brain is firing there and how much activity is going on with the person with OCD versus the person with no OCD. So there are biological things that are different between people who have obsessive compulsive issues versus not. So we do classify OCD as an anxiety disorder, but it has its own unique manifestations that help the patient either decrease or control their anxiety. You will need to know the difference between an obsession and a compulsion. Okay, so you can see in your orange circles to the side, we have anxiety, we have the compulsion, we have the relief. We have the obsession, we have the anxiety, we have the compulsion, the relief. Then the obsession, the anxiety causes the compulsion, and then there's relief. So the obsession is the recurrent or persistent, intrusive, and unwanted thoughts, images, or impulses. Once those are triggered, we have anxiety. How does the person get rid of the anxiety? They do the compulsion. That's the ritualistic or the repetitive behavior that the person carries out in an attempt to decrease their anxiety. And I'm sure we all know some of the basic things, washing your hands, checking rituals. You have to check that the doors are locked, that the coffee pot is turned off. Some people might have tapping, rubbing, or touching rituals. Some people have ordering rituals. Prayer or chanting rituals, and some of those are listed on 241 in your book. Your book kind of looks at them as self-soothing behaviors or reward-seeking behaviors. Self-soothing behaviors are people that maybe dermatillomania, skin picking, onychophagia, nail biting, trichotillomania, hair pulling. Some reward-seeking behaviors, kleptomania, so that would be compulsive stealing. Anomania would be compulsive buying. Hoarding would be excessive acquisition. And pyromania would be fire setting. So between the two, obviously, the self-soothing are things that you do to yourself, and reward-seeking behaviors are things that you outwardly do to deal with the obsession. And obviously, self-soothing, although if you do it to the extent, could be harmful to yourself, but you are not harmful to others. In reward-seeking behaviors, you are harming or hurting some other person or thing. I had a student, this has probably been about 5 or 6 years ago, but she raised her hand and said that she had the hair pulling compulsion. She said, I pull my hair out. And I said, how did you learn to deal with that? She goes, I still do it or want to do it, but I keep my hair pulled up so it's out of access of my hands. Because she said, if I leave my hair down around my face, she said, the next thing you know, my hands are up there and I'm pulling at my hair. So she said, I try to keep it up in a ponytail or a bun or something all the time, so I just can't easily access my hair, is what it would be if it was free falling. So, you know, you just kind of learn to adapt a little bit to the situation that you have. Now, obviously, in the reward-seeking behaviors, they're probably going to end up in jail, or we've all seen the hoarding show on TV, so those are life-stopping. Most of those people never come out of their home. They stop functioning. Even their family sometimes turns on them because they won't allow grandchildren, or they don't want to come into a situation or home that's filthy. So these things definitely affect a lot of other people versus our self-soothing behaviors. So some of our common obsessive thought themes that our folks have would be contamination. So there goes the cleaning or the hand washing or standing in the scalding shower because they're fearful of germs. A religious preoccupation or blasphemy that they may have. Aggressive urges, doubting thoughts, accidental harms to themselves, or sexual obsessive themes. Probably the one that we're most familiar with when you hear obsessive compulsive pieces, the obsessive thought is probably more of maybe a contamination or a doubting situation. Common compulsions, checking rituals, we talked about those in the book. I went over those. Exhibiting a rigid performance, arranging and ordering. Does this picture bother anybody? When I look at that, I just see somebody screwed up. Like, how the devil could you put a red square in the black theme? Now, are some of you out there, would you need to probably cut that out and get a red square and put in there? Would that always bother you?
No, because I can see the pattern. I see the gray one. If you didn't have the gray one there, it would bother me. So,
Okay.
now I can imagine that the gray one in here, but I can see the pattern continuing. So it looks at some point it's gonna be harmonious.
Okay. All right.
Maybe you just ran out.
Michelle, they didn't just run out. They screwed up.
I don't like it. I don't like it at all.
Yeah.
I wouldn't say it bothers me, but I would definitely notice.
Okay. So if you have OCD tendencies, oftentimes I'll have one or two students that there would be no way I could keep that. That square would have to be removed and replaced. I, on the other hand, just look at it as probably been messed up, and I would probably bring the person who brought it back in and say, okay, you messed up, so it doesn't follow the pattern. I wouldn't be obsessed with it. I would just be like, I paid so much I'm cheap, I guess. I would be like, I just paid so much money, you're gonna have to replace that because it needs to follow the pattern. Not that I would be OCD about it. I just would be cheap and say, I paid too much for labor, how could you mess that up? So, but people that have OCD, that you would never keep it like that. You would have to have that changed. Do you know anybody that has ordering issues where you have to have things in certain order? Like if I opened up your closet, would you have all of one color together, all of one style together? Anybody like that?
I do by styles, I don't do by colors.
By styles, okay, all right.
I feel like I'm like that with my kitchen. Like everything always needs to be in the same place.
And does it cause you a little anxiety if it's not?
Yes.
Yeah, okay. I think in some respect, a little bit of OCD is not bad.
Hello?
You get where I'm coming from? It does help keep a little bit of order to your life, but Ashley, would your kitchen not being in order keep you from leaving your home for the day, or would you just do it when you got back?
Yeah, I'd probably just do it when I got back, but it would probably drive me crazy until it was
Okay.
done.
All right. So for our OCD folks, they would never be able to leave before that was back in order. If you had a contamination issue where you had to wash or scrub because contamination was the issue, I would wash my hands repeatedly until in my mind that anxiety was reduced, and then I would be able to leave. Now I might be an hour late from work, and if I do this repeatedly, I may have lost my job, I think. Okay, so that's where OCD can interfere with everyday life, and those are the folks that we're talking about. So a little bit of OCD is okay. It keeps order in your life. It keeps you functioning sometimes. It keeps you from living like a slob, and it keeps maybe organization at work, but it doesn't keep you from your everyday life and performance and hinder those. And in true OCD patient, it does. It keeps them from leaving the house. It keeps them from finishing their work, etc. So how do we have our patient and family deal with people that have OCD? Well, we need to define OCD and assist in the recognizing the patient's symptoms that they have. We review the importance of openly discussing obsessions and compulsions and the anxiety that it causes. We want to emphasize medication compliance. It is an important part of OCD treatment for them. And we want to discuss behavioral techniques for managing anxiety and decreasing OCD symptoms. Suggestions for families. We want to teach them to avoid giving advice. We want to teach the family to avoid trying to fix the problem. We want to teach family to be patient with their own discomfort, because oftentimes, depending upon what the compulsion is, it bothers the family member more than it bothers the person who has it. Teach the family to monitor their own anxiety level. Sometimes you just have to take a break. Sometimes you need a break from your spouse. Sometimes you need a break from your kids because whatever they're doing is driving you batty. You just need to step away sometimes from situations. Take a deep breath, do something for yourself, and then come back to the situation. Because if your anxiety level goes up, chances are good their anxiety level goes up. And if they could stop it, they would stop it. But at this point, until they've had therapy or some type of medication or recognition of what that anxiety is, then, or that obsession, they cannot stop the compulsion. And sometimes they'll never stop the compulsion. We just need it to be at a point where it doesn't interfere with their everyday life. So maybe my compulsion is I have to wash my hands, but I've got it down to if I wash my hands 5 times, I can finally leave my house. Or if I've used the bathroom, if I wash my hands 5 times, I can leave the bathroom. So we just need them to get to the point where they can manage every day. They may always still have their compulsion and their obsession, but we need to make it in line with being able to function in everyday life. And when people are first found out, it is interfering with their everyday life. They cannot hold a job. It's hard for them to go to school, etc. And these can be little kids. I mean, you don't have to be very old to have obsessive compulsive disorders. If you get on YouTube, there's lots of good videos of children displaying their disorder to you and how it is hard to function. And it's very frustrating for parents to have children with obsessive compulsive disorder because you want to just get on with your everyday, and yet you have a child that needs to go through these ritualistic things, and it can be hard to manage. So the treatment for this, they do combinations of medications. You can see your first line medications and your second lines. Antipsychotics sometimes is what we're going to use for them. SSRIs. It just depends on how they respond, what's effective for them, and then you can see that if they're resistant to it, we get out second generation antipsychotics, Seroquels, risperidol, things that will help them manage so that they can live a fairly ordinary life. So there are some, you have a box on page 247. It's a Yale Brown Obsessive Compulsive Scale, and it's just questions that they ask, and they can put them on a scale to see where they fall. Their history, their general appearance and motor behavior, what do they look like? Their motor and their affect, are they overwhelmed by their anxiety? Their thought process, their content, do they have obsessions out of nowhere? Where did they come from? So those are all things in the assessment process that the psychologist or the psychiatrist will be looking for. Do they have judgment and insight? Are their obsessions, do they view them as irrational, but they're unable to stop them? They have powerlessness? What are their roles in relationships like? We talked about sleeping and eating disorders with anxiety. The same thing comes into play with OCD. Some possible diagnoses then that your book talks about for our obsessive compulsive disorder would be anxiety, ineffective coping, fatigue. Think how tiring it has to be to have these ritualistic behaviors all the time. We know that a lot of them with contamination issues have a lot of breakdown of their skin, breakdown of sometimes of their whole body, burns, those kind of things because of the contamination issues that they have. Interventions, therapeutic communication, relaxation techniques and behavioral techniques, daily routine completions. They'll actually work on, like when we have people that have suicidal thoughts or they have self-harming thoughts, that we have them do contracts, and they contract that if they have the idea that they want to harm themselves, that they'll contact somebody. We have them do daily logs so that they kind of make a pact with themselves that instead of washing their hands 10 times and it taking an hour to get out of the house, maybe we'll contract that we'll work on 45 minutes. So you'll only do it for 45 minutes and then leave the house. And then once you accomplish that, we may contract to only do it for 30 minutes. So eventually we can get it down to you're only spending maybe 10 minutes and then you can get out of the house. People that check their windows, just keep going from window to window and checking the locks. Check the locks, check the locks, check the locks. And they have to do it so many times. Maybe you'll contract that they'll only check the windows 5 times before they leave the house. And then eventually we could get it down to maybe they only check the windows once or twice before they can leave the house. So we need them to get to the point that their routine is more of a basic daily routine and they can live life. They can get to school if they're a K through 12. They can get to college. They can get to work. They can get to church. They could get to a function, something that they wanted to go to without washing their hands 25 times. Self-awareness, need to understand how and why their OCD behaviors work. OCD is a chronic condition and it involves a lot of bizarre thoughts and behaviors. And that's hard for the person on the outside to see. You just want to say, stop. Why do you do this? They don't know why they do it sometimes. OCD treatment is dependent upon meds, daily structure, because these are structured people. We need to continue to have that structure, and they have to have long-term behavioral therapy. And the biggest thing here is that you need to avoid fixing the patient's problems. And I think that's where family get into trouble and have a lot of anxiety themselves, is because they try to fix the patient or fix their family member. Some other disorders to consider: body identity integrity disorder. This is where they feel incomplete. They may actually desire to be disabled. They may desire to be paralyzed, or they may desire to have an amputation of one or more of their major limbs. Hoarding disorders, I think with the hoarding show that's on TV, I think you get a very good idea of what those homes look like and the anxiety that comes along with the person that has a hoarding disorder. And then body disturbance disorder. These are the folks, and you see these on, and I hate to say that I watch them sometimes because I'm just intrigued that you would do this to yourself, but these are the people that have cosmetic surgeries over and over and over again. And the best one I can think of is the young lady that wanted to look, or she desires to look like Barbie. And you've seen her surgeries, and I just think, do you ever look at yourself in the mirror? Because she was way prettier before she tried to be Barbie than after she's had it. But obviously she has a body disturbance disorder. And a couple of those plastic surgery shows will actually bring up this disorder when they talk amongst themselves. They believe that they probably have some type of psychological disorder that's causing them to keep coming and having cosmetic surgeries. So there's lots of good things on YouTube. There's a good one on Howie Mandel. If you look up a 2020 interview with Howie Mandel, it's about maybe 12 minutes, and he talks about his OCD and coming up as a child. And obviously money allows him to do some different interventions than what you or I could do, but he puts a pretty good perspective on how somebody with OCD deals with their everyday life. So if I didn't have this daggone share screen thing, I would bring him up, but I'm afraid I will lose you if I do. But look it up. It's very short. It puts a good perspective on OCD behaviors. Okay, so I would say for your exam, you need to know your various, what is anxiety? What are some treatments for anxiety? How does anxiety interfere with our everyday life? What are some physiological things? We need to know panic disorders, that they do represent themselves as a physiological response. They're oftentimes seen in the emergency room before they can get a good handle on that they have panic disorder. How do we treat that? Let's see. For our obsessive compulsive disorder, I would be familiar with the different types of compulsive disorders that there are. I think they're fairly easy. I mean, they have funky names, but you all know what a kleptomaniac is, so you know kleptomania. A few of them you just kind of have to learn that they're nail biting or skin picking, but be familiar with those. be familiar with some of the treatments that we try to get them so that they're probably never going to get rid of the compulsion that they have, but we need to get it smaller so that their life isn't consumed by their compulsion. Let's see, what else can I tell you about those? It's a couple interesting chapters. I think you have to be really into psychology to be in depth on some of the treatments and stuff they do. But for both anxiety and obsessive compulsive, we just need them to be in therapy so that it doesn't consume their life, so that they can manage to get out and live a normal life. And then safety, always safety with these folks. Okay, but remember, if they're having a panic attack, we want to make sure that we deal with their physiological safety first and then deal with their mental safety next. Okay? All right, so read over those, and then if you have questions, just let me know. I teach next week again, so let me know about any questions that you may have in regards to that. And at the end of your chapters in your book, there are some questions that it will quiz you over the chapter. You may not know every one of them, but you should be able to get most of them answered, and then your answers are towards the back of your book. All right, so I'm going to stop sharing this one. And why don't you take a 10-minute break and come back around 11:15. Let's do that. Go get something to drink, use the bathroom, and then we'll do laryngectomy.